Welcome everybody to our part two of the streamlining sessions at the start of our MDT improvement program. So hopefully some of you were able to attend our previous event. This is the sort of second part. So we've got a good agenda today. We've got a couple of case studies and conversations from Elizabeth Bright from Cornwall and from Ellen Quinney, who's from the North East London Cancer Alliance. And then we're going to do a bit of group work to finish up the session and for you to make connections with some of the other members of the improvement program. So just as a way of welcome, certainly you haven't seen this before. My name's Matt Noonan. I am head of improvement for GIRFT Elective. Previously we were called Elective Care Improvement Support Team, but from as of yesterday we are now part of the GIRFT improvement program. Welcome to everybody. Hopefully you have met some of us in the past. Some expectations for today. So cameras on where possible, especially if when we get to the group work. We want to ask questions. Please do use the mute while people are speaking, presenting. When you come back from group sessions, remember to put yourself back on mute. We really want active participation. So we've got a couple of talks today. Please do ask questions. So as we're going through, please do think of questions. That's a really good opportunity to make use of the experience of other people doing our talks today. Obviously, also please listen. So try not to do emails when people are talking. I will turn mine off because I am guilty of that as anybody. Please use the chat. So you're welcome to ask questions at the end, or put questions in the chat throughout. We'll give the speakers opportunities to do questions at the end, unless of course they want to take them as they go through. And finally, sort of stay open-minded. So we have I think really positively lots of sort of differing opinions sometimes around some of this stuff, especially streamlining. It's got some challenges to it. So please do stay open-minded. Please be receptive to different perspectives. Treat people with consideration and courtesy as you'd expect to be treated yourself. So thank you for joining, and I am going to hand over to Elizabeth Bright, who's from Cornwall, who's going to talk to us about the urology MDT. So Elizabeth, I will hand over to you. Thank you for joining and presenting for us again.
Thank you for having me again. Right, so I've done this session before. It's just an example of what we've done in Cornwall. It doesn't mean that this will apply to everybody, but it's just gives you an idea of what can be done. Fine, so if we could go to the next slide, please. So just by means of a bit of background, the cancer MDT was essentially introduced back in 1995. And it was with good intentions that every cancer patient got discussed so that they had a standardised level of care. But the problem with that is that our workload increased, our MDTs became unmanageable, and it led to translational discussions. And so in 2017, the Cancer Transformation Board with the Department of Health started to look at this and thought about ways that we could actually maybe streamline our MDTs. And this was actually at the time also given the backing of Cancer Research UK. So if we flick to the next slide. So the following year, from a urology perspective, GIRFT looked at this and noted that we were spending quite a lot of time as urologists of our DCC on MDT working. And they also obviously realised that this is only going to become an increasing problem because we have an ageing population, particularly in urology. We've got a high proportion of cancer workload compared to benign workload. And actually, unlike other surgical specialties or other specialties, we deal with 6 different anatomical cancer sites. But despite all of this talk, there was still no shift in practice. So everybody was still discussing every case. If we move on to the next slide, we'll see how then this sort of got talked about a bit further before anything got implemented. And so we moved to 2020 with NHS England and NHS Improvement now actually setting out some guidelines to try and encourage people to think about streamlining MDTs. And with these guidance, it just gave ideas of how you could say which patients could and couldn't be streamlined, determining by who'd looked at their pathology, their radiology, which clinicians have been involved. And if it was clinicians that were going to sit in that MDT anyway, then you're probably safe to streamline them. If we flick forwards again, we can see that this was responded to by BAUS, the British Association of Urological Surgeons, in 2021. And in their section of oncology meeting, so these are urologists that have a particular interest in oncology urology, they took a poll of what types of patients they thought could be streamlined. That was then put into a guidance document that was published in 2023 in the Journal of Clinical Urology. So next slide will show us what they came up with. So although we have 6 cancer sites, prostate, bladder and renal are our main bulk of our workload. So they identified patients within those 3 groups that could be suitable for streamlining. And then I'll show you in the next slide how we've gone on to implement this in Cornwall. So if you flick forwards, please. So streamlining and implementing standards of care is actually only one change we made in 13 changes we made to our MDT. We had a huge overhaul of how we did things. A lot of our changes were admin processes. We had changes in personnel. We actually took people out of the MDT, put other people in. We had a real distribution of workload compared to how it was before. We implemented effective follow-up clinics. So they were 5 days after the MDT, so patients' pathways were suddenly getting shortened. And as I say, one of these changes was agreeing and implementing standards of care. Now, all of these changes were designed by myself at the time, because I was the cancer lead back then, and our urology MDT coordinator. And these were all agreed at what's called a urology away day. So we had a whole morning or whole afternoon where every person who sits in the MDT was invited off-site, so they weren't then disturbed by other factors. And we all sat in a room and we thrashed out what we thought we should and shouldn't do. And we all agreed it at the end. We then implemented that, and we then agreed that we would repeat the away day 6 months later to make sure we were all still happy with what we were doing. It was working, it was effective, it was safe. And also to produce an iterative process where we could change things, move things forwards again. So if you flick to the next slide, I'll show you what our standards of care are in Cornwall. So for us, this works well. Again, this doesn't work for every different specialty, but for us, we don't discuss benign pathology. We don't discuss surveillance scans post-treatment where they haven't shown a recurrence or any concerning features. In terms of bladder cancer, the follow-up for bladder cancer and the pathways, the patient treatment pathways are quite formulaic. So again, as Baus said, you don't need to discuss low-risk bladder cancer, so we don't. We don't discuss recurrent bladder cancer where the histology won't change the current treatment or follow-up. So we know for a lot of our bladder cancer patients, they're frail, they're elderly, we're actually not giving them aggressive treatment. We're almost giving palliative treatment to keep them ticking along. So why discuss the pathology if that's not going to change? For renal cancer, we're getting increasing numbers of incidental small renal masses detected on CT scans for other reasons. Many of these are in frail elderly patients, whereas small renal mass is completely irrelevant. We're not going to treat it. It's not going to change their life expectancy. But we were having all of these patients added by every man and his dog around the hospital to our MDT. So we said, no, we won't discuss those. We'll only discuss the ones that have been seen by us in clinic where we feel they need to be discussed. And obviously many patients who have a small renal mass are on what we call active surveillance. So they're getting, say, CT scans every 6 months. We don't discuss those. There's no point in discussing a whole load of scans every 6 months if actually their plan is to remain on active surveillance. And as long as you set out a good criteria at the beginning for if and when the patient would want to change their treatment plan, and that is then adhered to going forwards, be it many years down the line, then that's an appropriate way of streamlining these patients. If we flick to the next slide, in terms of prostate cancer, again with Baus, they deemed that low-risk prostate cancer didn't need to be discussed. It could be a standard of care. We know that these patients, the national guidance is that they should be on active surveillance. For our patients, we did have a certain restrictive criteria here in that it was patients over 70 with those specific parameters in their PSA blood test and their histology and their MRI findings. And that was just because at the time when we decided it, that made some of the members in the MDT panel at the away day feel more comfortable. And ultimately, this was all about everybody feeling comfortable. For patients on hormones, where that's their ceiling of care, they don't get discussed. We're not going to change anything. Patients on watchful waiting aren't discussed. And patients where they don't have any cancer found on their local anaesthetic prostate biopsies. For us, our post-prostatectomy, cystectomy and partial nephrectomy histologies are discussed at a specialist MDT, which we do jointly with another hospital. And our penile cancers are a regional, pan-regional Southwest MDT. Again, they're discussed in those MDTs. So again, there's no point in discussing them at our local MDT. That's just repetition and unnecessary workload. If you flick to the next slide. So what were ultimately the benefits of our standards of care? Well, they reduce the length of our MDT. We were initially having up to 60 patients. It's down to about, I've put 25 to 40 there, but I think it probably on average runs about 30 every week. That has ultimately led to better engagement from our MDT attendees and reduced fatigue. And ultimately, that's improved quality of discussion for each patient. We aren't having these quick translational discussions. We're having more in-depth discussions about the patients that need to be spoken about. But more importantly, because we've implemented standards of care, we've actually empowered our MDT coordinator and our CNS team to have more autonomy in providing these roles, in deciding who gets a standard of care, who doesn't. And actually for them, that's given them a more enjoyable role overall and more ownership of their patients. I think that's it. I don't think I've got another slide, have I?
No, I think that's it. Thank you so much for that. I'm going to kick off the questions and hope that other people join. So just a couple of things though. You talked a little bit about the fact you sort of changed personnel around. What in terms of criteria, etc. How did you approach that in terms of, I guess, deciding who should come and who shouldn't come? It'd be quite interesting to understand your thoughts around that.
Well, the MDT, when I started as the cancer lead, was very traditional. It was the way it was because that's the way it had always been done. And I think just because nobody bothered to think about it. So that meant that every urologist in the department was expected to come to the MDT. And actually, as time's gone on in urology, we've all become more subspecialized. We're less generalist urologists now. So we're having urologists sat there who had very little interaction with cancer patients, who say maybe, a kidney stone surgeon, who didn't really then bring any patients to the MDT, but they were expected to be there. And some of them, we had some surgeons who didn't want to see cancer patients. They don't like treating cancer. They want to do the benign work. So they didn't want to be there either. And so it was a matter of negotiation, really, in that what was the point in them sitting there? Because that meant that no other activity was going on in my department on a Thursday afternoon other than the MDT. So actually my managers loved it, because the clinicians that I almost gave them carte blanche to say, do you not want to come anymore? Would you rather do a theatre list? I can arrange a clinic for you. I can arrange this. It worked well. It's about negotiating and making it work for everybody, really.
Thank you. We've got a couple of hands, so I'll leave my other question to later, just in case someone else asks it. So, Robin, do you want to come in, and then I'll go to you, Victoria?
Yeah, thanks, Elizabeth. I was just wondering, you have obviously made some quite firm decisions with your standard of care as to who is being discussed and who isn't. I was just wondering if you got any pushback on those decisions, either from inside or outside the MDT, and if so, how you approached those.
Yeah, I mean, I think a lot of the pushback was from the people who didn't have an interest in cancer. So when we were first trying to implement this, as I say, those clinicians who weren't that interested in treating cancer patients, their fail-safe was to bring everything to the MDT. So again, by making sure the right people are in the MDT, you're actually all singing from the same hymn sheet. And yes, we did have pushback on some of the things. Like I said, with our prostate cancer patients, we could go further than that, and the guidance allows us to go further than that, but we hadn't, because that's what actually made people feel a bit more comfortable at the time. And that didn't have to be the consultants. That could have been the cancer nurse specialists, or that could have been the radiologists. It was everybody's voice, everybody's opinion that we had to take into consideration, because ultimately, if they're all going to be sat there being part of the panel and we say this is a collective decision, then everyone has to be comfortable with that collective decision. So yeah, we did get some pushback, but you have to negotiate and maybe move the barriers, the parameters slightly.
Victoria, do you want to come and ask your question?
Hiya, just a question around the empowering of the MDT coordinator at CNS team. Can you tell me a little bit more about that? What do you mean to empower them?
So our MDT coordinator is very much part of the urology team now. We could not do without her. She's very much the gatekeeper of what goes on to the MDT, and she will, if because she works to a very strict sort of protocol, pro forma about what does and doesn't go on there, who can and can't add to the MDT, and then if she's unsure, she's got a sort of pathway of people to ask, so she can go through the lead CNS, through the cancer lead, which is another consultant. It's not myself anymore, but it's another consultant now, and has a mechanism of asking and checking. And she actually is allowed to go back to clinicians who aren't part of our MDT, say, actually, this doesn't fit the criteria for coming to our MDT. The mechanism is you need to now refer that through to a consultant to an outpatient clinic or whatever. So she's in charge of the MDT. It's not just literally her old job of putting a load of patient names down on a Word document that then we all looked at on a Thursday afternoon. She actually now manages that MDT, how it functions and who's on there and who isn't. And our CNS team, because they are very much involved with nurse-led pathways for a lot of our cancer patients, right from the start. Many of our cancer patients don't see a doctor until they've been diagnosed with cancer. So the nurses are leading the pathway all the way and deciding who is a standard of care, who needs to go on to the MDT, who needs to go to X, Y, and Z place. But they're all protocols that we've written, SOPs that we've written, so that everybody can be autonomous and be in charge, and we're not having repetition of workload.
So in terms of your MDT coordinator, are they an administrative part of the team?
Sorry, are they an administrator?
Or do they have a clinical background? Or
no, they're purely an administrative admin person. They're no clinical background. And she does do another MDT, but the urology MDT I think is the bulk of her work. And as I say, whereas before, I don't know how other hospitals work, it always felt like the MDTs were a separate group of people sat in cancer services and never just came to our MDT for a few hours a week and then went again, and we didn't really know them, we didn't really know their name. For us, Michelle is part of the urology team, and she's been with us so long now. We've gone through all this process with her, this sort of learning and developing process, that actually she can guess what we're going to say probably most of the time for each patient's pathway before us or the CNSs have said it. And she runs the MDT. She calls out the patient. She then documents and she says, right, this is what we're doing for this patient. Blah, blah, blah. Can I make sure we've done this before we move on to the next one? She's very much the leader of the MDT, because you can't have a clinician leading the MDT, because if you've got a clinician leading, they're not listening to the discussion and they're too busy typing, and they're not actually being involved with making a decision about the patient.
So I guess that part is very similar to what we would do in terms of our MDTs, but it's the triaging of patients onto the MDT and the empowerment of the MDT coordinator, where the responsibility sits with them, that is different to how we would do it.
Yeah. But I think she's always got that backup of liaising very, very closely with our CNS team and our cancer lead. So as I say, if it's obvious to her that this patient isn't suitable for the MDT, it's not that we ignore that patient. They just go via a different route to urology. They don't go via the MDT, because the MDT can otherwise become the dumping ground for everybody not wanting to make a decision and just going, excellent, right, that patient's off my workload now, they're on to someone else.
Just a question, do you have a pre-MDT?
No.
Controversial, Elizabeth.
Thank you.
Thank you, Victoria. I think that was a really interesting discussion. Baljeet, do you want to come in and then?
Yeah, it was just to explore that and just add something else. So I think I was just kind of hearing that. So you don't have any pre-MDT or mop-up sessions, Elizabeth, and it sounds very much onus is on the clinic coordinator or the person, because is that not a lot of pressure on one person? Because a lot of our clinic coordinators would defer to the clinicians to make the decisions. They certainly will be able to track, but not make any sort of clinical decision, and that's part of the challenges, I would say.
So our MDT coordinator doesn't make any clinical decisions. It's admin decisions. But one of our major points is that you can only add somebody to our MDT if you are a member of the MDT. So like with most processes now, because they're all our ways of doing things in the hospital are electronic forms, it used to be that anybody could add a patient to our MDT, no matter who they were in the hospital. You know, as long as they had access to our Maxims computer system, they could add someone. And that was just ridiculous, because then we'd all sit there saying, who's this patient, looking at each other saying nobody knows anything about this patient, why are they on here? So she gatekeeps that sort of aspect of things, so that if they're being added by somebody who is a name she doesn't know, a name she doesn't recognize, she will go and question that and go and find out why, rather than just automatically it being added, if you see what I mean.
So, I mean, maybe it's the different special, but I guess, yeah, because we have a lot in colorectal straight to test, so that they would come, you know, they have no clinician who has actually seen this person. They are gone for a test, they have a abnormality identified, and unless somebody sits down and goes through it, they don't have any ownership until after the MDT. They are really sort of just tracked through the pathway at that time point.
Yeah, and as I say, it doesn't, not every way of working works for every different specialty. I think one of the previous sessions we held, the upper GI team was saying they have a lot of benign pathologies that turn out not to be benign, so they do need reviewing again. And your colorectal pathway is probably similar to our colorectal pathway, which is similar to our prostate pathway. Our prostate patients don't meet a doctor until they're diagnosed with prostate cancer. And the first doctor they meet could be me saying, would you like an operation? Or it could be an oncologist saying, would you like some radiotherapy? The rest of the pathway is done virtually, with their only contact being a telephone appointment by our nurses.
No, thank you.
Thanks, Brad. I mean, I think that's the crux here. Some of the principles is how do we sort of mould them to the right, how they work with each individual specialties. I mean, I've worked with MDT coordinators for a long time in my previous role and this role, and it is amazing how well they know MDTs once they've been doing it for a while, and giving them some responsibility within sensible boundaries can be really, as you say, and as you found, it to be really empowering, and actually can get, they can be quite fierce when they need to be as well, which is always quite handy sometimes. Anne, do you want to come in and ask your question?
Yeah, I'm interested because I manage the MDT coordinator team in our organisation, and I'm just interested to know what the cover arrangements are and how they work, because obviously there's a lot of knowledge in that one MDT coordinator, and how do you replicate that when they're on leave?
Well, we notice when they're on leave, because we do suddenly have patients on the MDT that we're all saying, why is this person on here? This person didn't need to be here. Because invariably they will default to the safest option, which is, well, I'm not quite sure about what to do with this patient, so I'll add them anyway. But that's, that's 1 week every so often. The vast majority of the year, we're lucky we do have Michelle with us, and it runs very efficiently, and it works, and it makes everybody actually enjoy the MDT rather than dread the MDT. I
just wondered if you had a magic formula that I need to apply.
No, unfortunately not. I mean, we've got I think it's like everything. You can't have a single point of failure, so you can't have a single person that is the wonder person that runs everything. But if you've got rules and regulations written and SOPs written that somebody can at least try and follow for the 1 week that they're covering the person who usually does it, then it does work on the whole. It's not that it's suddenly a horrendous MDT the week she's away. It's just there's a handful of patients, 1 or 2, that you'd be like, oh, they wouldn't normally have got on here, but it doesn't matter.
I guess, Elizabeth, you can link in with your CNS team as well, can provide that support when there's times of cover. Great. I was just going to ask one last question. I know we've slightly run over, but you talked about, obviously you agreed some criteria which didn't go as far as potentially we were able to do. Have you got a process where you might review that every 6 months or a year? You mentioned you sort of got back together after the initial changes, but do you see that you maybe in time people get more confident in sort of changes? Because I think that's completely reasonable. And this is like small steps are completely fine if you just sort of iteratively get more confident in things. I'd be interested in your view of that.
Yeah, absolutely. I mean, our initial sort of meet again was 6 months then. I mean, we're now years down the line from this.
Yeah.
So, and then we met another 6 months. And then I think at that point we sort of all went, well, we haven't really got much to discuss. So we met a year later, and, you know, and almost like an operational business meeting, your MDT business meeting that you'd have. And actually, we're sort of tweaking around the edges now with it. We haven't actually reversed anything. We haven't gone, oh, actually, that was a bit too risky to do. We need to go back. But as I say, we're tweaking around the edges, and we're just sort of slowly creeping forwards. And there's more things that we've done even in the last couple of months in terms of our prostate cancer patients that I haven't put on here because I'm not completely up to date with it myself, because it's another MDT cancer lead now that's doing all the changes and the tweaking as well. And as a team, we're constantly developing and going forwards. So that's good.
Brilliant. Thank you, Elizabeth. Thank you so much for that. I mean, for the people who've seen that for the first time, you won't be surprised when we asked Elizabeth to come back. It always generates quite a lot of conversation, really interesting conversations. Right, so we're going to move on to our next presenter, who is Ellen Quinney, who is the Programme Manager for Diagnosis and Treatment for North East London Cancer Alliance. I think, Ellen, are you going to share your slides?
I am, yes.
Okay, let's see if the technology works for handover. Perfect.
Okay. Just going to presentation mode. There we go. Can you see those okay?
Yes, we can.
Super. Hi. Well, thanks for having me. I think, you know, there's some similar themes with what Elizabeth has just discussed. I think we came at it from a slightly different angle. So I work for the North East London Cancer Alliance, so not sitting within a trust. So this, similarly to Elizabeth, formed part of a wider programme. There were multiple or are multiple ongoing MDT improvements, of which streamlining is one. But we, as I say, came at this from an alliance level, and therefore wasn't a specific trust or a specific MDT, but trying to implement on a much broader scale. So that's possibly why some of the sort of processes and things that we've done may differ. So just worth bearing that in mind. So I'm just going to talk a bit about our streamlining implementation overview, the journey, the process so far, and where we're at currently. So you guys will, I'm sure, will be familiar with the NHS England streamlining guidance. So we wanted to support MDTs to implement, evaluate the impact, and then develop resources for ongoing support or MDTs in the future that might want to implement after the programme might not exist anymore. Worth noting, we've got a few members of our kind of MDT improvement team. So Ben Lamb is the clinical lead for the programme, and he's my MDT guru. He was one of the authors in the paper, the Baus paper that Elizabeth mentioned, so has been really instrumental in kind of MDT improvement for a long time in his career. We also have Tiana Sukup, who's an implementation scientist at Imperial. So again, has really helped us with a lot of the kind of making sure that our implementation process was really evidence-based. We've also recently recruited a fellow to help us with some of the evaluation and data collection. So we started out with a wide engagement strategy, webinars, talk to all the ERG, so our expert reference groups that are led through the Alliance for each of the tumour sites. And based on feedback from them and what we saw, we started out with those 4 tumour groups, so breast, urology, lower GI and gynaecology, so across North East London. We've subsequently added skin and brain that we're working with now and we'll build into our plans for next year. So can't emphasise enough the importance of mapping out MDTs. So these were the 4 tumour sites that we started with. No tumour group across North East London has the same MDT structure. Some have local specialists, some just have specialists, some just have local. So it really varied, and your implementation process is therefore going to vary based on the structure. So would highly recommend making sure you've got that on paper, because it does make a difference into how you would implement. This was the framework that we used for developing the SOCs. So again, based on the one that was published in Baus, we iterated it slightly and used this as our framework for developing the SOCs with those 4 tumour groups. These, according to the guidance, the Streamlining NHSE guidance, these SOCs should be signed off at alliance level. And so we when we developed these, we took these through those tumour group expert reference group meetings so that they had sign off from representatives across all of our trusts within the Alliance. This is an example of our urology one. This is one of our pilots that we have going actively, and has been added to and amended. Worth noting that the pilots that we have going, as Elizabeth has mentioned, they have been added to. So we kind of encourage people to start small. They're iterative documents and can be added to, and actually have been added to since they've been put into use. So they're not set in stone. It's not kind of now or never, so worth reassuring MDTs of that. And this was just to show how many SOCs or how many cohorts of patients have been included in SOCs across the tumour groups. So actually 64 and counting different cohorts of patients that could be streamlined. So then we move into implementation. So that's just the guidance that I'm sure you will all be familiar with. And this was just the process that the guidance sets out in terms of how triage or how streamlining, should be implemented. So through your triage meeting, cases get decided or put into simple or complex cases. One has full discussion and one can have a SOC applied. And there are audit at various points in that process to ensure cases are being streamlined appropriately and recommendations are happening in accordance with SOCs or discussions. This is just a breakdown a little bit more of our process in those phases. So establishing the SOC's engagement, implementation, identifying early barriers, auditing how those SOCs are working once implemented, and then development of that toolkit for ongoing support for MDTs. So we started, once we developed the SOCs, we started by sending out a more detailed questionnaire to each of the meetings. So SOCs, tumour group level across the Alliance, and then these questionnaires were meeting specific, sent to each meeting. This was to get a lot more background information, so how those MDTs were running currently, who attends, how are outcomes actioned, live recording, etc. So to give us some background information. We then use those questionnaires to develop a recommendation, a bespoke recommendation pack for how that specific MDT would implement streamlining, what things might need to be in place for them to be able to get to a point where they could implement streamlining. So this was just an example for one of the packs that we'd created, so things that they needed to look at. So when was your triage meeting going to happen based on when your MDT takes place? Who was going to be at it? How are we going to ensure that those staff could attend a triage meeting? Will you have the information that you need in terms of imaging or pathology for that triage meeting, etc. Really important in those meetings was for us to kind of tease out what were immediate critical actions that were needed in order to step up a streamlining pilot, and what were other actions that would improve MDTs. There are lots of things, it's not just about streamlining. There are lots of other improvements within MDTs that are needed, but for the purposes of stepping up a streamlining pilot, we, for example, we don't need to address all your hardware issues that you might be having within your MDT meeting. Yes, that needs, that feeds into an MDT improvement, but it's not streamlining critical. So try not to get bogged down in fixing absolutely everything, but focus on what's totally essential to be able to pilot streamlining. And this is just a little bit of kind of where we are now, although it might not be totally up to date. So create the pack, meet with the MDT to discuss, agree the actions, critical, non-critical. Actions get completed, and then we can initiate a pilot, and we will support with pilot evaluation at the end. MDTs are at various stages for various reasons. Some specific to the MDT, some trust-wide. Some actively declined and said, actually, we don't think this is right for us. We think our MDT is a bit small and it probably isn't worth us stepping up the the resource that would be needed to triage, because the whole meeting itself is only an hour long. So, which I think is a really interesting point that I'll mention again later. So this was urology MDT. So urology is a big specialist MDT, and this was just an outline of what the streamlining process would look like for that particular MDT, with sort of days of the week and how bits would feed into the triage meeting and lists would be produced, etc. And what we found with an initial evaluation of that pilot was that on average we could streamline out about 30% of cases, so discussing 60% of those that were referred. Worth noting, they weren't all, as Elizabeth mentioned, they weren't all streamlining in terms of application of SOC, but some of it was about looking at incomplete information and rejecting referrals because they either weren't appropriate to come, didn't need an MDT decision, had incomplete information, or for a few different reasons. But on average, overall, we could streamline out over 30% of cases. So the triage meeting was capped at an hour, so didn't ever take more than an hour any week. It consisted of the coordinator, a consultant, and CNS. This was a 8-week pilot, but it's ongoing. Really interesting that there was a unintended or unknown benefit that happened with pathology, and actually they really, whilst they were initially unsure about having a different deadline for triage meeting, etc., actually it really helped them to be able to split their workload through the week a little differently. So instead of having a focal point of the MDT meeting where there's a sort of mad surge of activity, it helped them, or helps them, to separate their workload out for patients that they will know will likely be streamlined, to disperse the workload for them a bit. We have got an ongoing challenge, again, I'll come to in a minute, about sort of transitioning into business as usual in terms of that triage resource. So this was just to touch on audit. So again, the streamlining guidance talks quite a bit about audit. So how do we know that we are streamlining the right cases, that the SOC is working as it should be, and that those decisions are being adhered to and followed, etc., and that we have all the information that we need, or that the guidance says that we need to be able to streamline. So we, using the guidance, have developed an audit tool as part of the programme. And this was just what the guidance has sort of talked about in terms of ongoing audit. So we need to make sure that the SOCs are sort of, and continue to be fit for purpose, and we have all the information that we need. We should audit that regularly for both SOCs, but all discussed cases. And how we build that in sort of going forward is a slightly different challenge. And again, so for us, we are now looking at resource development. So after this programme may not exist in a few years or however long, that MDTs who want to implement streamlining have got resources there to do so, like the questionnaire, like the template that we've built along the way. So for us, we will continue to work with those MDTs or the tumour groups, as well as onboarding a couple more, create the resource pack. It's been a long process. It's intentionally been a longer process because we wanted it to be evidence-based and sustainable. I think some of our trusts were hoping it might be a quick fix, but it's not. Well, not the approach that we've taken anyway. We're also exploring how technology might help us to do some of that pre-MDT sort of information gathering. I think it's worth, we have obviously talked to and looked at, there are AI streamlining software, but I think for us it's about building trust in the streamlining process to start with before we move on to AI supporting with that in any way. And one of the things we'll probably look at yet next year is how we use Medic tool to decide which patients should even be having MDT discussion, because what we've seen across our patch is that some MDTs will say, oh no, we don't discuss that, we don't take that to discussion to MDT, whereas some do. So we need a bit of consistency in what cases are even getting referred, or is there an over-reliance on MDT decision making. And just learning points for this programme. So yeah, build trust. The MDTs want to know that this is safe. So, you know, for us, that's been really important to build in the evaluation and audit. Be mindful of definitions and the difference between streamlining what we've now sort of termed as hygiene prep meetings. So when we approached MDTs to talk about streamlining, they would say, yes, we're doing streamlining. Yeah, we do all that already. Actually, what they were doing is a kind of a hygiene prep meeting to see if all the information was there, to have a look at, you know, that kind of pre-MDT meeting. It wasn't streamlining as we mean it, which is application of the SOC and moving patients out of full discussion. The program's been totally reliant upon enthusiasts, and, you know, focus your energies on those early adopters. We've now got a challenge into how we transfer that or transition that into business as usual. Some MDTs in this program just haven't shown a huge amount of interest, and we have not kind of ploughed all our energies into those. I think for us, it's going to be about getting robust evaluation data from the ones that have early adopted and piloted, and then perhaps kind of revisiting with those slower to change once we've got a bit more of a case for change. One of the things we've also suggested to them is whether they'd be happy for us to support with a kind of hypothetical audit. So if you had streamlining, these are the amount of cases you perhaps could not have discussed and what you could have saved. Streamlining might not be appropriate for all MDTs. There's a assumption that it will be, but actually there's not loads of research out there about whether it is. And what we've seen in our small trust, we've got one trust that's much smaller in size compared with the others. Like I mentioned, that resource to step up the streamlining meeting, they didn't feel that was beneficial. So actually something interesting that's coming out of this for us is that it might not be best for everybody, especially if those MDTs are smaller. Starting small versus benefit. So Elizabeth mentioned it. So we start small, and we encourage MDTs to start small in terms of the cohorts of patients they put on that SOC, which I think is right, because you can build on them. But what that means is that when it comes to implementation, if the MDT sees that actually there's only, you know, 3 or 4 cohorts of patients that could be streamlined, is that worthwhile? So it's a bit of a balance. Transitioning into business as usual. So again, it's now about sustainability, and we've relied on enthusiasts for the pilot, but that's not sustainable, and it's a kind of single point of failure because it's one person doing the triage. And we think we can avoid job planning, which obviously there'll be resistance from trusts because it's resource, by actually looking at doing it on a kind of rota basis and having a consultant rotate and doing it kind of 1 in 8 weeks. And actually we could give them some time back to say that they don't need to attend the meeting kind of the week after or something, to mean that it doesn't create an additional ask on resource for the trust. But we're working through some of that at the moment. There's a bit of uncertainty over ongoing audit provision. So we as a programme have got clinical fellow and provision to do some audit, but how do the MDTs build in that quality assurance long term? You know, again, things like peer review will all take resource. So how do we sustainably do that? Creating the toolkit as a programme legacy. And then, you know, just this wider issue that we've sort of touched on about what MDTs are being used for. One of our challenges where we haven't implemented streamlining, that MDT has a lot of benign cases going through it, and that's for tracking purposes essentially. So how do we, and interesting when you were talking about the kind of colorectal straight to test models, is that the right use of the MDT, or actually can these patients be moved, and that's a sort of that's a clinic or a paper clinic that needs to be done or set up, rather than MDTs being used for that purpose, and that's, you know, that's a much wider issue. And that is the end of me. I'll stop sharing. Thank you.
Thank you so much, Ellen. Really interesting. Like, yeah, really interesting. I mean, I think the pilot is really helpful in terms of trying, I guess, transition to BAU, because it does give you some evidence to tackle things. But these things are always tricky when it's sort of cost to save more cost as opposed to just savings, which obviously everybody director of finance licensing. But I think, you know, the resource that goes into MDTs, if you suddenly said, right, we need to run a second one of them, suddenly everybody would be like, oh, well, we'll just pay for a PA to do a bit of triage, and that'd be a lot much cheaper than putting all the PAs for all the consultants and various other clinical members of teams to attend. So we're going to move on to some conversations around that in groups, and it'd be really interesting if you've got any thoughts or success stories in terms of how they have done that locally. I'm just going to open the floor to any questions, otherwise I might ask. I think Robin.
Hi, Ellen. Thanks so much for joining us again. A really great presentation. It's always fantastic to hear the work your Reliance is doing, because I know you're doing so much in that area of MDT improvement and streamlining. So thank you for sharing. Just pulling on those learning points you talked through at the end, which are fantastic. Appreciate you've kind of approached this from an alliance point of view. So multiple providers, lots of different MDTs, lots of different specialties. But knowing what you know now at this point in the programme, what would you say for an MDT, for example, who's here today, who's considering implementing a standard of care? What would you say would be their starting point? What would you recommend as their first step?
Good question. I don't know whether Elizabeth's probably got more experience with doing it at a local level. As you say, mine's very much alliance. I think you need to make sure that you've got buy-in at a couple of different levels. So obviously you need your MDT members on board and your leads. I think it's going to be really hard if you haven't got that local enthusiasm. I think gather a bit of evidence by all means. You know, we've got evidence that we can share as a group to show the benefits. I think you're better looking at kind of bigger MDT. Urology lends itself really well, breast lends itself really well. Your kind of bigger hitters in terms of case numbers. But I think it's also important to get that operational and kind of cancer management lead support as well, because ultimately, especially for us as an alliance, I haven't got jurisdiction over those MDTs. I can't force them to do anything, so I can try and win hearts and minds. But actually I am, and I have, and we do call upon the trust leadership to say, look, we've kind of led your horse to water, please can you make it drink? And sometimes you do need somebody, you know, you need to make sure you've got the people that have got authority as well to kind of be engaged and on board with it.
Thanks, Helen. Thanks, Robin. I'm just interested in a bit, you mentioned sort of hypothetical audit where you're like trying to predict. Can you just have you done that, or have you got an idea how you would do it? Just interested in terms of, I think it's quite an interesting thing for people potentially to do, but who would do it, and how would you see it working? Because it's good to get, again, there's another chance to get sort of evidence of it in advance of making a change.
Yeah, so it was one of the thoughts that we had for those kind of slower to adopt MDTs. So obviously we've got the SOCs that we could audit against, but it was or what we planned, we haven't done it yet, but is to kind of look at an MDT list for one of the MDTs that hasn't implemented, and hypothetically, what could we have streamlined based on the SOC that we've got for that tumour group? What could we have streamlined out of that meeting? And then we, you know, have got a bit of data to say, actually, you know, you could have streamlined 40% of those cases and saved, you know, it's hard, I think, with this, because we're not automatically saying you'll get a time saving and here's that time back and here's how you can put that in financial terms. What we're saying is you can use that time for more complex discussions, which is a harder sell to the trust because you're not putting it in kind of pounds and pence and time. But the hypothetical audit would be about sort of saying this is what you could have saved in terms of caseload discussion. We would use, as I say, we're lucky because it's an alliance led, we've got the clinical fellow that can do that for us, but I think there probably are some local in-trust SHO audits, clinical fellows that you perhaps could utilise as well.
Great, thanks, Ellen. Elizabeth.
Thanks, Ellen. I just wanted to come back to the point that you made about some centres feel that streamlining 3 patients out isn't worth it. I would argue that it is. I'm yet to find anybody who tells me they would like to sit in an MDT longer and discuss more patients. So if I said to somebody, would you like to sit here for another 3 patients or not, I can guarantee you they'd all get up and walk out the room. And that list of patients that aren't discussed, it's small to begin with, but it gets longer as time goes on and people's confidence grows. So you can actually also see the benefit of it. So I would argue, do start with your 1 or 2 patients, and you look at them and you briefly look at them yourself. For us, they're at the bottom of our MDT list. They don't get discussed, but the consultants will briefly cast their eyes over them before the MDT and go, yeah, I'm happy my name's on that, and my name says they don't need to be discussed. And that list will get longer and longer. And all you get is happier radiologists, happier pathologists, happier everyone.
Yeah, I think that's very much true. I think, again, really hard to quantify and very hard to sell, but making a meeting more effective and more enjoyable for the people there, i.e. making, because the discussions are useful and will be invaluable, and definitely will help patients, I'm sure, and the sanity of consultants and CNSs and all the other people that attend these meetings. Right, we are overrunning, so apologies, terrible chairing. So I'm going to hand over to Robin, who's going to take us through the next section of the session.
Thanks, Matt. And thanks again, Elizabeth and Ellen, for your presentations. You are both more than welcome to stay on and join in with our action learning set, but equally appreciate you might have some commitments and need to drop off. So our action learning set again today is going to be based on group discussion and also sharing things in the chat box as you did last time. And it's a real opportunity to talk through some of your challenges, some of your solutions, some of your actions with your peers. So the people in the room at the moment, people from other MDTs, because they may have already tried what you want to do and have some feedback for you. They might have some new ideas. They might be able to give you some more support on those. So we really do encourage people to break into these groups and have a really good discussion about some of the issues. So we're going to start off on a similar theme to what we did in the last session, which is to think about your barriers. So specifically for this session, we want you to think about what the barriers are to implementing or effectively using standards of care in your MDT. And then we're going to take this further and build on this idea. So to start with, we're going to do a chat bomb. Hopefully you're used to doing these by now because we've done them a few times. So if you could pop in the chat box, what are the barriers to implementing or effectively using standards of care in your MDT? So type them in the chat box, but don't press send yet. I will let you know when. Type as many as you like as well. So, don't feel it's just 1 or 2. Go wild. If you have some barriers you want to talk about, please do pop them in. And we're going to give everyone another minute to do that. So please continue thinking. It could be that some of you have a standard of care, but you find that it's not being used very well. So in those terms, what actually is holding it back from being used effectively? Okay, I'm going to give everyone 30 more seconds to have a think and type it in the chat box. But remember, don't press send yet. I will let you know when to press send or enter. Don't worry, Anne, it's okay. You're just very keen. We all are. Okay. Couple more seconds. All right, can everyone please press send, enter, however you phrase it, on your chat box to send all your barriers through to the chat. Thank you very much. So, as Anne started us off, engagement and time. As Robin had said, MDT is used as a way to ensure diagnostics are reported. Baljet has agreed with time. Natalie said team engagement, time restraints. Georgina said lack of national guidelines, complexity of cases, safety concerns, again, engagements. Laura has agreed with time. Oh, we've got quite a lot of resistance to change and engagement. Victoria said mindset, managerial engagement, financial constraint. Nancy said again time. And Ambika said time. Thomas has said time and engagement. Oniru said technical and IT issues, which is also a consideration. Fantastic. Thank you very much, everyone. Okay, the next step. We're going to get you thinking about solutions. So what we want you to do a chat bomb again. So if you want to type in the meeting chat box, what could be the solutions to these barriers? So not necessarily the barrier you've typed in the chat. You could pick one up from somebody else and type solutions to theirs. And we really want you to go a bit wild on this. So as many solutions as you can think of to as many barriers as you can think of in the 2 minutes. They can be completely outside the box. They can be really far-fetched. And you think, actually, probably no way we're going to do that, but it doesn't matter. Somebody else could pick up something from that and implement it. So if you have a think, what could be the solutions to some of those barriers that put in the box? So have a look at what other people have put in, pick up from them what the solutions could be. So what's the end goal? And ultimately, it's the solution to implementing or effectively using standard of care in the MDT. So I'm going to give you a little bit more time for that. Let's do another 30 seconds. We're down to about 10 seconds now. If everyone can carry on typing into the chat box, and I will let you know when to press send. Okay, time up. So if you want to press send, enter, however you want to say it, and fill the chat box with some of the solutions to the barriers. Okay, oh, quite a lot coming through. Thank you, everyone. So Victoria started out, better communication, clearer leadership, networking, AI, money, learning. Natasha has agreed, sharing learning, strong and passionate leadership, involving stakeholders, clear on shared goals. Anna said team building, leadership changing, exemplar MDTs. Neru has said time, technical and IT improvements, robust systems. Marla has agreed on clear roles, training, communication culture, electronic records. Georgina has said discuss with the team, have a consensus, really good word, and invest time in improvement. Robin, take the team out for dinner. I would obviously agree with that. Yes, very much so. Get the whole team together to get involved. Absolutely. Elizabeth said tackle one thing at a time and keep it small to get comfortable with change, which is fantastic. And Ambika said effective triage before MDT, quarterly team reviews to boost engagement and shared learning. Some fantastic solutions there. Thank you very much, everyone. So we're now going to take it a step further. So as Ellen mentioned in her presentations, there are often actions needed to move towards a solution. So in your breakout sessions, we're going to move everyone into groups. What you're going to discuss and identify are the actions that are needed to move towards a solution. So in the groups, every person should choose at least one solution from the chat box. And again, it doesn't have to be your own solution. You can pick up any solution that's in there. And what we want everyone to do is identify up to 3 actions that could help move an MDT towards that solution. So an example here for you, if a solution is to have an additional PA for triage, actually what needs to be done for that to happen? Because that's not going to happen out of nowhere, unfortunately. There needs to be something done to get you to that point. So again, try and think outside the box, especially if you've tried something before and it hasn't worked. The idea of getting together as a group is that you support each other and make suggestions. So, please get involved, ask for advice from the other people in your group, offer suggestions, offer from your experience. And also make a note of some of the actions you're coming up with, as you're going to be sharing those in the next chat bomb. Once everyone in the group has finished discussing at least one solution, you can move on to discussing a second. Again, pick another one from the chat. So, for example, you could start with discussing how to invest time in MDT improvement. So, you know, what actions are needed to get towards that. And then you could move on to talk about team building. So what actions could move you towards better team building in MDT? So it says 20 minutes at the bottom there. I'm actually going to give you 15 so that we have a little bit more time to discuss the actions when you're all finished. And I'm going to ask my colleague Crystal to start moving everyone into their breakout groups.
Thanks, Robin. So you'll automatically be moved now. It sometimes can take a few seconds, and then you'll automatically be brought back when it's time. So we'll see you on the other side.
Right. So appreciate some people had to drop off the call because of other commitments. So some of the sizes of groups may have varied. Some people have had to leave a little bit earlier, but hopefully you all had some really valuable discussions. So now we're just going to move on to sharing some of those discussions. So hopefully you all have at least one or two actions that you've identified that could move towards solutions. So what we'd like you to do is in the chat box. Again, we're going to do a chat bomb. So could you please type briefly what solution you chose? Obviously, you don't have to type out in full, just give us an idea. And then at least one action that you've identified in the chat box. Obviously, if you've identified more than one action, so if you've identified 2, 3, 4, 5, however many, you can put as many as you like in the chat box. But just to make it easier for people, we'll go for at least one action. So if you could start typing those in the chat box. Again, please don't press send or enter just yet. I'll tell you when to do that. And I'll give everyone a minute or two just to start typing. Also, as well, obviously we're doing this in the chat box, but if anyone would prefer just to put their hand up and come on and discuss verbally what was discussed in that group, you are more than welcome. Please just pop your hand up and we'll come to you when we've hit go on the chat. So you're going to give everyone about 30 more seconds just to finish typing. So again, if you could type in the solution as well as the actions just to help us marry them together. And the idea is of sharing all those in the chat boxes so that everybody can see them. So it could be that you've identified a solution and some actions that somebody else in another team would really appreciate having some guidance on. Okay, so if everyone can finish typing and now hit send or enter or however you like to do it and send all those actions into the chat box, please. And again, if anyone would prefer to put their hand up and discuss it verbally, please do go ahead. Okay, quite a few coming through, and my chat actually isn't keeping up with that many are coming through, which is fantastic. Okay. Oh, really detailed from Victoria and their group. Thank you so much. So some action there about organisational engagement, about understanding from other areas, selling to management, highlighting risks and drawbacks, which is fantastic. Also some actions around financial, working differently or smarter, using different software, and learning how to access transformational budgets, which is fantastic. So Georgina has said for triage, allocate adequate PAs. Yeah, absolutely. Laura has suggested getting all teams on board, more regular meetings outside the MDM. That's actually a theme we come up against quite often when we look at these presentations of people sharing their experience of MDT improvement. I think a common theme is that they've all had away days or time outside of the MDT to talk about things, which is fantastic. Elizabeth has said need team engagement and get an SAP or an SAC that everyone feels comfortable with, pre-MDT meetings. New has said having a pre-meet for casing where imaging is not available in the case of IT issues. Thomas has suggested for clear protocols. Better quality referrals through to the MDT. Reducing wasted slot, making it easier for MDT coordinators to prep, which is fantastic. Anne has suggested, engage another clinician as a champion. That's a fantastic idea. Yeah, absolutely. Also picking up on Elizabeth's presentation as well about having rota for MDT chairs. So I've seen this quite a lot. So you have one MDT clinical lead, but actually the chair changes every week, and they all do their part in MDT triage. Natasha said in terms of engagement, engage where efficiencies can be made. Fantastic. Bring a peer clinical lead to support, provide opportunity to understand the clinical lead's concerns. Yeah, some fantastic actions there, everyone. Thank you so much for discussing those. And the idea is that hopefully this can help some of you who are starting to make those steps in terms of streamlining. So, you know, you've identified your smart aim, you know where you want to get to, but actually there are steps before that smart aim that need to be taken and actions that need to be put in place. So hopefully that exercise has just helped you think about that in a little bit more detail and share some thoughts with others. So thank you so much, everyone, for engaging. Obviously, everyone can see all those actions in the meeting chat, so feel free to pick up from there and ask any further questions of any other members of the group if you'd like. Right, I'm going to hand back to Matt now. Thank you.
Thank you, Robin, and thanks everybody for sticking around and engaging with that, because I think it's these things that help people move forward with their program. So I think we've got a couple of reminders before I sort of sum up. So we've got some QI support for all the teams over the next couple of weeks from Great Ormond Street. So if you don't have a meeting, you should hopefully all have meetings with them. But if you don't, get in touch with that email address, which takes you to Robin and team who will help get them set up. But yeah, I would definitely advocate making use of that because they're really helpful, and can really help sort of you get to a helpful place in terms of this process. And then next one, please. I think is about our next session, which is in a few weeks' time, which is around to provide a communication in processes. So again, hopefully we'll see you then and others from your team. Really, it's quite a good session again to try and help us think about what we can do differently or the small changes. I think just reflecting on today. So thank you to the two speakers. I know that this is going to drop off. But hopefully you guys found that useful. I think from both of them we saw, you know, starting and making changes was the way that they got into this, and you know, it doesn't have to be massive change. Finding time in people's diaries to take them away from the day job to put some thought into this and to talk to each other. I think it's really evident, you know, the clinical leadership is important, which is why it's so important to us to have you guys, the clinical leaders, on this call, because it's you that can help drive the change along with your support staff, with your MT coordinator, the clinical nurse specialist. So I think, yeah, hopefully that's been helpful. I think, you know, sometimes about just disaggregating the principles. Not everything you've heard today might fit, but it doesn't mean that not all of it won't. And I also hope that the process that Robin just took us through at the end there has been beneficial, and you've got some thoughts around things that you can take back and try, and the changes made. So hopefully the next time we run one of these, we'll have people from this session doing presentations about the changes they've made and the improvements that they've seen, because that's the point of this, is to try and help give us the focus and the time to make those changes. So I will wrap up then. So thank you for attending. Hopefully we'll see you again in a few weeks' time for the sessions we just talked about, and have a good afternoon for the rest of the day. So thanks everybody.
Thanks everyone.
Thank you.